Hello, and welcome to today's webinar, Embrace the New Era of Utilization Management with Advanced Technology. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC, or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Elizabeth Crowley, Vice President of Clinical and Care Management Solutions, and David Jackson, Vice President of Healthcare Management, both with EXL. At this time, I'd like to turn the floor over to our speakers. Welcome.
Thank you, and thank you all for joining Dave and I today. We're hoping to have a very engaging conversation and present to you some thought leadership and some transformative approaches to the challenging process of utilization management and how to think about that differently and leveraging advanced technology and analytics to maximize and transform program delivery. There's a lot of market pressures that are forcing us to take a look and modify the process. We have some great headwinds. There's a lot of customer frustration, a lot of administrative cost pressures, provider frustrations, and the ever prevailing CMS regulations that seem to change with the tides and keep us constantly adjusting and adapting to market demands. But there are some tailwinds. Sorry, everyone. The slides are going a little crazy. There are some tailwinds that we can help to minimize the dramatic shifts and gain some traction to help us deliver more effective programs. Medical appropriateness, so we can ensure that we're leveraging this function and making sure the best decisions are being made. And this is increasing ever more rapidly because of new treatments and the robust medical guidance that is being influenced. We have coverage policies, new plan designs, coverage exceptions, government mandates that are constantly changing and providing more structure and more framework in a program. And we have our payment integrity function, and we typically don't think about payment integrity coupled with but if we take the learnings of payment integrity and see where we have gaps or leakages or opportunities and bring that more forward or more to the left, like we like to call it, and make those changes and modifications up front, the friction and payment integrity goes away and the chasing of the dollar is minimized, and it brings those savings, those efficiencies more forefront in the end-to-end utilization management process. Underpinning all of this are four, key themes and concepts that need to be maintained in a program. Obviously, compliance with regulations, both at the federal and the state level. Enabling AI and other efficiencies in operations, removing that operational cost burden and making OpEx and performance more effective. Continuing the monitoring of data-driven gold carding programs, particularly where we have opportunities for providers to have a less restrictive experience with a payer or a more independent, autonomous member centric delivery, and making sure that we're monitoring and ensuring that those programs are delivering as expected. And then auditing, and that is both on the claim side and the data side to ensure more real time and more proactively that we are achieving the desired outcomes of all the operational opportunities and levers and program changes that we are employing. So there's some levers that we can think about when we are approaching a transformative redesign of These options positioned here are intentionally done so to be thought-provoking, with the intent to break the cycle of managing in a traditional transactional manner. So at the very far left, we can consider eliminating all prior auth, whether that's inclusively across end to end. Maybe that is line of business specific, Medicare only, commercial only, or maybe it's within specific value-based arrangements or certain provider groupings that there's the ability to just remove prior auth altogether. Automate where appropriate and implement new tech. This is probably one of the deeper areas that is being explored. It's not meant to replace humans, but it's made to maximize human effectiveness, clinical engagement, and clinical appropriateness. Increasing auto approvals and gold carding. And we'll talk about how to think about this in a different way, not the historical approach to gold carding. And then finally, maybe we just need to maintain the status quo. Maybe there are too many other things going on in the local landscape and in your own organization that making big changes to the program just isn't the right thing to do at this time. But there are still some things that we can do in that approach to optimize that program and bring data to the forefront of decision making as much as possible. So when we dive deeper into eliminating all prior auths, the area of focus here in the benefits and challenges. So in eliminating prior auth, obviously the benefits are improving provider satisfaction, early access to care for members, and reducing operational costs. Some of the challenges, though, are increased medical costs when you remove the process, prior auth process. Controlling utilization can become challenging. And there's also that risk for member safety and quality of care concerns without the process. But if we are thinking about eliminating prior auth in any aspect of your organization, what we are looking to do is to ensure that unintended costs and quality consequences are not incurred. So there's two main areas that we can focus on to drive to this focus. One is transparency and coverage. So data gathering from structured and unstructured data help ensure that files that are submitted on the back end, claims that are submitted on the back end are inclusive of everything necessary to demonstrate appropriateness. We can also leverage the data gathering to make sure that the policies and information that is accessible to our members and providers are inclusive and clear, and that there are not gaps in the documentation that lead to then transactional gaps in claim adjudication. We can create missing information alerts in the claim submission process. Again, more upfront, more real-time alerting so that there's not downstream time delays and abrasion in operational adjudication or member and provider experience. Leveraging conversational AI for automated voice intake and status checks. We found this to be a great enabler for provider satisfaction, where they can engage with an AI agent, ask multiple questions, dig into multiple scenarios when they need to, so they're not stuck in a call queue waiting for a live agent to answer the call. And then streamlining workflows in these buckets where prior auth is being eliminated. It's also the time to streamline the workflows as much as possible, using that data and optimizing any medical necessity review that is necessary on claim submission, and making sure that that is as effective and efficient as possible. And in the post-pay area, it's a little of what I mentioned before, is how do we look at what we're learning in post-pay, and where do we see gaps? Where do we see claims either coming in significantly upcoded, unbundled, things of that nature? Where do we find even adjudication errors within our own processes, that the pricing or the network or the allocation was done incorrectly? And where we're finding those gaps, making sure that we're fixing at the source and the root cause, instead of just relying on post-pay and payment integrity type of processes to catch those activities and those scenarios. When we think about implementing new tech and infrastructure, um, benefits, that's consistent and accurate determinations and adjudications, right? When there's more technology and more automation, we have more consistency. There is operational cost reduction when we can automate pieces of the workflow. It's less human touch, less interaction. We can reallocate resources to more meaningful functions. So instead of having resources be burdened with administrative tasks, they can leverage their skill set to be towards the most effective activities and potentially repurpose staff for more opportunities within the organization. And there's reduction in off-to-claim leakage. When we have the technology to ensure appropriateness on the front end, it mitigates abrasion on the back end. Some of the challenges, though, is investment, right? The investment around tech is a significant one. There's a great learning curve, both in the technology from a model's point of view, as well as the end user adoption, change management point of view, and that needs to be carefully orchestrated and managed to achieve the desired positive result and intent of technology. Clinical adoption challenges are probably the most relevant and prevalent, and engaging in bringing providers and clinical end users to the beginning of the conversation and design helps to champion those stakeholders and allow these technology solutions to be seen as a benefit and not a replacement to function. So this approach, right, is to automate but not replace all human function, right? So there's never the opportunity to replace all, but where can we replace to make the most effective use of resources and process. And we break this into three sections: front, middle, and back office functions. In the front office, this is intake, extraction of data, looking at unstructured data. Is the submitted information complete? We can use AI and NLP and LLMs to actually read the submission and make sure the large context categories of information are included and it's not a blank page or 5 pages of the same information. We can use EMR data abstraction to alert for missing data. We can use conversational AI for automated intake and to outbound to providers to alert of missing information. In the middle office, this is where our core end users are being augmented and supported. So when we have horizontal integration of policy, operations, customer service, claims, and bringing all of those functions into a common data set and using technology to drive to the same outcome, abrasion is mitigated and end users have the ability to operate most effectively, satisfy providers and member inquiries quickly and accurately. Ongoing data and reporting to validate program outcome and provider performance is important here, as well as using data for provider education. So if we're finding subsets of specialty or certain providers that are continually being prompted for missing information or their clinical is not complete, we could use that data to support and educate those providers and change that behavior. Back office is really focused around automated quality management, including data accuracy and workflow adherence. And this is both at the process level and the end user level. Call quality audits, making sure what is spoken is actually what is being documented. And medical necessity decision quality audits. And this is not just the standard IRR or monthly quality, but leveraging technology to do focused audits on new policies or significant changes to existing medical policies or a new device, a new med, a new service program is being put into place. You want to make sure that all of the clinicians are applying criteria and rendering decisions in an equitable fashion. So it has the ability to be very focused, very targeted, and more real time than retrospective audits that are typically done today. Increasing auto approvals and gold carding. So benefits, obviously, provider satisfaction, removing the administrative burden from their office staff, improve claim to auth adjudication, improved claim adjudication, removing that auth to claim friction because auth is not required, early access to care for members, reduced operational demand. Obviously, some volume is being removed from the prior auth work stream. Challenges, though, their data and analytical models need to be created to identify, support, and monitor gold carding and auto approval programs. Defining gold carding eligibility can be a challenge. And also the ongoing provider outcome monitoring and communication of that of the provider's performance in their gold carding program sometimes is a barrier or a challenge. When we think about these, there's the focus here is it's not a provocative point of view, right? Gold carding and auto approval has been around, but how do we use the data to think about it differently? How do we use the data not just to look at attribution models or utilization pattern models, but maybe looking at true quality of care outcome models? And even if a provider only sees 1% of the population in a specific specialty, but they consistently demonstrate quality and never have lacking clinical. Those are providers that should be included in gold carding programs, not just your heavy hitters, heavy utilizers. So when we think about new data and analytics, what other data types should we bring in? Is it just utilization? Do we look at post-pay data and look to see if providers are asking for one set of services on the front end, but then attempting to bill for other services on the back end? How do we leverage provider and member CRM data to drive that? Is there satisfaction? Is there disgruntledness? Are there grievances or complaints around providers? And how do we leverage all of that data to make the best choices on how to go about gold carding and auto approval processes? And using advanced analytics, once those models are put into place, continuously monitoring them. I think historically over time, I've been in the business for 25 years. Sometimes gold carding is almost a set it and forget it. And it's not always deeply monitored unless there's a problem, and either an uptick in utilization, medical costs, or an uptick in complaints, or some other driver that is causing us to look deeper into gold carding. So using data in a more real-time way just gives a better operational and ongoing performance metric around gold carding. It also allows us to do provider management and provider education more robustly. And I think the provider management portion has largely been undervalued and underutilized. Ensuring that the models and the reporting that are put into place are supporting and arming our provider network representatives with relevant information, accurate information, to have those meaningful conversations with providers, both for great performance as well as areas where performance may need to be adjusted, or areas of opportunities to help change provider behavior, or to help them leverage technology better in their own practices to help reduce some of their admin burden and things of that nature. And then we come to maintaining the status quo. So the benefit, there's really no internal change management demands, right? So you don't have to worry about engaging multiple teams across the organization on how things are going differently. Even your own organic prior auth teams have no real change. Challenges, though, is if the inability to impact medical costs from a prior auth point of view. The continued increased provider abrasion around right? That'll never go away. I think even if we made it a perfect process, there will still be dissatisfaction in the entire process end to end. Members will continue to be dissatisfied, either because them thinking that services and process is not working effectively, or they're hearing those messages of frustration from their physicians. And there's risk to the ASO business, right? So when we have our ASO business who are watching the dollars, right, just as much as they're watching outcomes, when there are all these pressures in the industry around prior auth, and you know our organizations are saying we're really not making material changes, will that risk that business? Will it drive some potential dissatisfaction in those relationships? So even if that is what needs to be done right now, or no meaningful change, we can still do things and leverage functions and opportunities in our organizations to make change. There's always the ability to improve provider and member communication. So whether that is connecting member and provider services with more actionable information from within the care management platforms, any other population health type of activities, and bringing next best actions to the front line that interact with members and providers can help and educate and ensure that the process can be effective as possible. We can try to embed early warning metrics for missing information. Sometimes that's just at the level of nothing was submitted. It's difficult without deep technology to assess what has been submitted, but anything that can be done to catch early when a key piece of information is just not there. And then minimizing friction, using the data that we have. So can we be a little bit more robust and a little easy to navigate procedures that aren't covered, or when other carriers are primary, when there's a duplication of services, upfront, when there's coding and billing errors. So how can we just communicate more effectively around topics like this when we're really not changing the process, but we're trying to make the process that we have in place the most effective and the most ease to navigate for members and providers and for our internal teams. Okay. So at this point, I think we wanted to get some feedback from all of you.
Thank you. As you can see, a survey has appeared on the right-hand side of your screen. If you can make sure you're not in full screen mode in order to participate in the survey, that would be appreciated. And the survey reads, which of the presented levers is your organization considering? Is it eliminating all prior authorization, or automate and implement new tech, or increase auto approvals and gold carding, or keep the status quo, or both 2 and 3, which would be the automate and implement new tech and increase auto approval and gold carding. So we appreciate your participation in this survey, and we will go ahead and publish those results momentarily. Again, which of the presented levers is your organization considering? And we'll keep that open for another few seconds here while we just round out the survey. And then I will turn it back to our speakers to discuss the results. So again, thank you for your participation in this. And I will be sharing the results with you all momentarily. And I'll turn it back to our presenters.
Thank you. Very interesting in the results, kind of where we aligned. And I think you all can kind of identify that both 2 and 3 we positioned purposefully because we have been seeing and we know that that's where a lot of focus is. Interestingly enough, no one selected eliminate all prior auth. So that is interesting, and that even in some aspects that prior auth is still here to stay, but there was a pretty fair breakout, either automating a new tech at 35%, but 2 and 3, 50%, half of you responders are leveraging both of those approaches to optimize utilization management. And that's a really great sign to know that we can attack these problems in a very dynamic way using multiple tech solutions, operational transformation opportunities, change management, with internal and external stakeholders, right, to really drive outcome performance. So as we move to the next kind of section of our conversation, we're going to dive a little deeper in how AI being infused into operations can enable benefits. So again, thinking about it from a front, middle, and back office point of view, um, in the front office, it's again largely around digital intake. So what does this mean? Automation extraction of structured and unstructured data from multiple files, missing information alerts, conversational AI for intake status, any type of status checks, things of that nature, streamline workflows and optimize prior authorization lists, um, easily accessible pre-certification requirement indicators, and where administrative approvals are appropriate and needed, taking care of them in an automated fashion. Typically, these drop to non-clinician resources, and how can we, automate that and give more real-time feedback. When we think about middle office, there's two areas. There's clinical determination, and then there's an aspect of denials, appeals, and grievances, both requiring review, summarization, interpretation of sometimes very large and complex medical records, various forms of medical records, from images to surgical notes, medication lists. You all know the gamut of documentation received. Some is electronic, some is form, some is handwritten. So the complexity just in that nature of our business is there. But with AI, it has the ability to automate guideline, policy, and clinical summarization. So we can automate and ensure accuracy of the appropriate guidelines selected based on line of business, jurisdiction, type of service, inpatient, outpatient. Does that default to a national standard? Does that default to an internal organizational standard? And really helps with that. And then reads the clinical information submitted against the requirements of those guidelines and presents a summarization to the clinician, which then enables them to more effectively render their clinical decision. So we call that clinical decision support. Where appropriate, we can automate pieces of the workflow, right? So AI is not meant to remove the function and the skill and the benefit of clinical review, but it can help with automating pieces of that process that can be done when quality and outcome and effectiveness and consistency is achieved. It also can help automate the determination notification process and helping with medical director documentation and making sure the documentation truly is at the appropriate language level, the readability level that is necessary in the various lines of business. It can also help prompt for any type of network steerage that is required or an opportunity to help drive to quality or control costs without the end user having to remember that this is another possibility or another option in reviewing the clinical request. The AI also helps with automated routing. So things that come in for clinical review that never could be reviewed or determined by a clinician, or the clinician's step was simply to summarize and try to build the case presentation for the medical director so that they could render their decision. AI can do that. So it actually removes the step of the clinician doing the typing and the summarization. And that summarization is done through AI and presented to the medical director. So we have a lot less time lag from request to determination. Again, with guideline summarization, very clearly calling out element by element what is meeting and evidence in the clinical submission and what is not. And again, the documentation assistance to the physician and the medical directors, particularly for the member-facing component of documentation. And then we move to back office, and that's where we think about nurse quality audit. And what is spoken is what is documented for any telephonic interactions. We can use the quality audit for real-time coaching and process improvement. we can do call quality. So it can be side by side call and case quality. Lots of automation and NLP based models that extract um, business continuity, process validation, and things of that nature. The beauty of using AI is you can do a 100% audit if necessary, whether if that's on a person, a process, a service grouping, however you need to do that. When AI is infused into the process, though, I just want to, kind of really articulate this concept is it does not need to be done in a big bang approach. And honestly, it's not recommended to be big bang. Meaningful and purposeful analysis of your process, data accuracy and data availability, as well as the impact to the overall program and the outcomes that you're trying to achieve, all of those need to be considered and evaluated to prioritize what point of the process are you going to start with infusing AI? And are you going to start, even if it's in the intake, do you start only in a fax channel, or do you start it in a portal channel? Do you start it with a large provider group? So all of these things to think about. Where do you start it where you can quickly learn, identify where there's efficiency, early indicators of any, hangups in the workflow, and mitigate them very quickly with minimal impact. And then once that's established, it's a lot easier to scale and then bring that AI functionality across the entire end to end of that portion of the workflow. Let's take a look of exactly what is achieved when we bring AI into operations. So again, across the bottom is just meant to represent across all front, middle, and back office. Where we have turnaround time considerations, AI has achieved and delivered upwards of 60% reduction in turnaround time in that segment of the function. And where AI has been leveraged end to end, that's an overall end to end reduction of turnaround time. There's cost reduction, 20 to 25%. That's typically around productivity gain. So it's not necessarily hardcore cost takeout, but when you have increased productivity gain, you then have cost takeout. The cost reduction also, some of this is related to pure medical cost. The more accurate, the more consistent, and the removal of human error in medical necessity determinations allows medical cost adherence to be more accurate and more consistent. There is a 40% improvement in clinical review effectiveness. And then we have 5% accuracy improvement. And that is that human error or even human bias in the various clinical specialists that we have as nurses and physicians working in managed care and payer environment. Everyone comes with their own professional bias. So there's that little bit of bias even in how we interpret clinical and render decisions sometimes. In aggregate, what we see increasing is throughput, accuracy, efficiency, the straight throughput of the authorization. So those early indicators of missing information allow that process to run. Once the authorization has everything it's needed to run through end to end, it runs through end to end very quickly. Again, the speed to identifying missing information, clinical decision, and top of license performance. So we're allowing our clinicians and our physicians to use their knowledge as intended and not use their time to focus on administrative tasks and our quality checks. But what we see going down, right, is unintended medical director referrals, right? So if the clinicians are supported with evidence-based data, they're more confident in making decisions and less likely to send questionable cases to medical directors. Managing trends, right? Decreased handle times and turnaround times. More end-to-end accuracy and coverage. Member and provider abrasion is reduced. That's just speed to answer and speed to access to care. Unnecessary duplications. We're able to find duplications early. We're able to identify when information that has been submitted is submitted again, and we don't have to action that duplicative data. And it just reduces treatment delays and medical spend waste. So after running you through, specifically how AI can be infused in the process and some of the benefits, we have one more quick poll for you.
Thank you. And that poll is appearing on the right-hand side of your screen. Again, please choose the best answer that fits your situation. And the question is, what is your organization's largest barrier to modernizing utilization management? And we have 4 choices. Is it still developing strategy, lacks appropriate resources, or technology vendor limitations, or is it costs? So once again, what is your organization's largest barrier to modernizing utilization management? Again, thank you for your answers and participating in the poll. We'll keep it open for just another few seconds, and then we'll go ahead and close it out, and the presenters will address the results. Okay, and thank you for your answers. We're going to go ahead and close out that poll, and I will turn it over to the presenters to discuss the results, and I'll share them with you as well.
So the majority, close to 42%, you're still in developing strategy. So that's probably where most are. There's lots of things that can be done, and what is the most meaningful. And sometimes we get into analysis paralysis, right? And trying to figure out the best first step forward. And then secondly is cost, right? In your earlier response to poll of leveraging tech and infrastructure, as well as the gold carding and auto approval, that takes a lot of organizational resource, both internal and external, to design, develop, implement, and execute those functions and monitor them. So cost, I'm not surprised that cost is a quick runner up into some of the barriers. So thank you for that feedback. I hope that you found this part intriguing and valuable. I'm going to pass it over to Dave. He'll walk you through the rest of our topic today.
Okay, thank you, Liz. So I think Liz has given a great overview of kind of the considerations and what are the decision points that organizations are going through as they sort of make decisions around what to do with their utilization management function. So we did hear that the majority of you had said, hey, you're developing strategy, right? You're sort of contemplating how to get started. You're trying to come up with a funding strategy. We also heard a lot of you earlier kind of represented the notion that you really do believe that technology, sort of the combination of technology, in some cases gold carding and decision making around how to handle providers in a more I'll say specific way, that those are kind of top of mind. So with that backdrop, what do we need to do when we get started? And so I'm going to kind of focus on some of the data related and kind of information related baselining kind of activities that are important. I think the way that we think about this is kind of in 3 steps. The first is before you kind of start making adjustments and changes to your process and making in some cases policy decisions, what's the current state? Where do you what is your baseline? Use that sort of baseline and your goals and objectives to then sort of develop a utilization management modernization strategy. As Liz said, we're not thinking about this as a big bang approach. You should think about this as being targeted, where can you create the most value, what's the which journeys in the process can generate the most value? Where's the greatest source of friction, both internally and externally, and really prioritizing your strategy into those areas. And then ongoing monitoring, obviously, Liz alluded to this earlier. I mean, I think we definitely we have a fairly significant payment integrity business as well. And what's interesting, in an organization like ours that works in the utilization management operational space and technology space, and then in the payment integrity space, is we really see payment integrity gives an interesting lens into utilization management. It's downstream, right? And so through the lens of payment integrity, we oftentimes see decisions that are made around exclusions of providers for certain programs, be them, right? We're going to exclude this set of providers from payment integrity audits. We're going to exclude this set of providers from certain auth related activities. And those decisions are made and folks, right, kind of move away from them. And so, the notion is, hey, don't just, look at data on the front end, right? Have the data in place to look end to end across the operation over time is really, common theme. So I'm going to dive into each of these just a little bit more over the next few minutes before we open this up to Q&A. So in terms of access and assess your baseline is I guess what I would say, right? What is the current state? So it's pretty common with organizations that we work with that they tend to focus on the internal operation, right? Front, middle, back office from an operational efficiency perspective, right? And improving turnaround times. But if you sort of step back for a second, right, and widen the lens a little bit, you know and understand that, right, the purpose of utilization management in the first place is to address medical expense utilization, right? And so, we would argue that the first thing, right, that the starting point here should really be medical expense trend, right? What's happening with medical expense trend? What's happening with utilization, right? And how effective are your current policies and programs, right, at addressing the intended impacts on utilization, and what are the unintended impacts on utilization, right? Just because you turn on a policy doesn't mean that it's going to be 100% effective. And I think, using data across the end-to-end process and looking at the outcomes in claims that are associated with the actual, transactional process is really important here. It does require, that analysis requires that you've got some, foundational trend breakouts, right? Place and type of service, clinical breakouts, right? What are the service lines that are impacting utilization? What's the provider view on utilization, right? What's the impact of, at a provider system level, and then at a provider group level, and at an individual provider level. And then, some of the advanced concepts that I think, we're at the beginning of a kind of a new horizon in terms of having better tools to really focus in on utilization management policies as in terms of their impact on medical expense. And what I mean by that is generative AI really tools give us the ability to really evaluate policies. Policies are documents, right? Historically, it's difficult to look at a policy, right, and translate the impact of a policy on the actual medical expense impact, right? That's a kind of an indirect kind of approximation that's been done over years' time. And, right, actuaries, right, use some indirect assumptions in math when they forecast the impact of policy changes on trend. With generative AI, we now have the ability to ingest medical policies. We have the ability to compare them, right, across multiple organizations, and we have the ability to then empirically turn those policies into rule sets that are directly applied, and then essentially predict and evaluate the impact empirically of those policies on claims. And so that is a new horizon that is an area that we're seeing rapid advancement. And so I think over the next couple of years, you're going to see that as becoming a new, really sort of tool in the arsenal. And so then policy decisions, you can really take a more data-driven approach enabled by AI to really evaluate those decisions. And so, so the intent of this is to, I've kind of over-indexed on, right, the outcomes of medical expense, but really, we believe that's the starting point, right? What's the impact? What's your medical expense trend? How are your policies impacting that trend? Is there leakage between those policies and your actual medical expense trend, right? If so, right, form your strategy around correcting and addressing, right, those areas, right? And in effect, this is a little bit of an alternative strategy, right? Rather than thinking internally about, workflow, look at a macro level first and identify, macro level where to focus your energy. Then focus internally, right, on your operation. and the front, middle, back office that Liz was talking about earlier, right? Front end, right? There's significant opportunity, right? There's significant opportunity with the front end, right? To simplify and speed all of that, right? Sort of the documents and the non-structured data, unstructured data that rolls into the process. Significant opportunity to then, right, incorporate AI and generative AI in clinical summarization, right, to support the middle office and decision making. So start with a big picture, right? Start with the outcomes in mind, look at policies, and then focus on the internal front, middle, back office and look for points of friction, right? Use data to really then identify and prioritize, right? Quick wins, right? Versus sort of longer term gains. So that's sort of first concept around assessing your baseline. Next, what is the utilization modernization strategy, right? Okay, what do we do, right? With that information in mind, we've identified the key areas, right, where we need to do something different, right, with respect to policy, with respect to the operations, right? So, how do you go about that, right? What are the key components of that modernization strategy? So, what you see here on the page is actually the first bullet point actually isn't technology. Right? It's strategic transformation and change management. It's what's the objective you want to accomplish? Who's going to be impacted by that change that you're going to implement, right? What are the risks and what are the barriers to that change? And how can you design these changes with key stakeholders in mind, right? So this really is not a technology exercise, but it's really focusing on personas. It's focusing on the clinical works, right? The clinical staff, right? In their workflows, and how can you design this to make their lives better, right? Adoption of new technology is directly proportional to how it makes somebody's job and life easier in their work life. And so those considerations really, need to be an important part of the sort of first step in the process. The AI and digital transformation, right? The technology aspect of this. What I would say is, some of you've talked about in the previous Q&A, several of you, or a number of you, had identified technology concerns as a challenge. The way that we approach modernization is, number one, what is the technology that's available to you today? What are the organizational enterprise decisions that have been made around technology, right? In all likelihood, the hyperscaler, right, the technology that's available at an enterprise level may likely be usable, right, and configurable here. We can deploy it here in the process versus the idea that you have to go shopping for technology. We would say, get the lay of the land with your existing technology that's available, and then let's work to figure out, okay, how do we configure this, right? How do we tailor that technology to meet the needs of the stakeholders in the process and the clinicians in the process? And then lastly, the analytics, right? What's the data strategy around this? Once you start to make changes to policies, right, to operational processes, right, there will be things that will work well. There will be things that don't work so well, right? There will be intended and unintended consequences. And so having the end-to-end data and analytics across the operation becomes important to really, right, evaluate, right, what's worked and what hasn't worked. Our most successful work with customers from an AI transformation perspective has been work that really has started with a focused, journey approach. Let's start here. Let's make some initial gains in a 12-week sprint. Let's measure that impact and evaluate it. And then where do we go next? And what do we need to do to fine tune, right, the results? So this is not a right, magic doesn't happen here. This is really an iterative approach, right? It's a series of experimentation, right? Make a change, evaluate it, fine tune it, right? The technology, your ability to deploy the technology will get better over time, right? As you gain experience. And that really, requires, again, a sort of a diligent approach to change management, to fine tuning the technology, ensuring that you have the data assets available that you need, right? Clean data, right, is the fuel for AI, and that you're monitoring using, sort of advanced end-to-end analytical capabilities. we kind of touched on ongoing monitoring, and I'm going to wrap up here pretty quickly. The ongoing monitoring really, ties to what we've talked about. So medical trend, right, and utilization and medical technology, right, are both dynamic, right? There are many factors that influence medical expense trend, right? There is a pipeline, as you all know very well. There's a pipeline of new technology, right, that is flowing through, right? That is on an ongoing basis. There's a right that pipeline is dynamic. The experience, right, of your membership is dynamic, right? Things happen over time. There are many factors that influence utilization. And so having an ongoing source of data, right, and information available to be willing to be ready to course correct, right, identify early indicators that are likely to influence utilization and then be able to look comprehensively at, okay, which of these levers are going to be solved via utilization management policy? Do we have leakage that's happening because of some system change that happened in our plan that we now need to address, right? What has happened? Has CMS guidelines changed, right? Have CMS policies changed? And is that now flowing through, right, through our operation into our expense, right? Number of factors. And again, having that discipline to have a cross-functional team of folks that are clinical experts along with your actuarial team and your data scientist team, right, and your AI, your AI team working together, right, as a cross-functional team really, will set you up well for success. So we've gotten through this. We've got about 9 minutes left to take some questions. I'm going to hand it back to our moderators to take a few questions.
Thank you. Thank you both so much for your presentation and for your expertise. And if you would like to ask a question, please use the Q&A box located on the right-hand side of your screen, and we'll jump into the questions that we have come in already. The first question reads, one of the allegations we have seen in the recent past is the unfair denial of authorizations of services done by AI. What is your opinion?
So, great question. I can tell you from an EXL point of view and thought leadership, we do not advocate nor employ our AI technologies or solutions to deny. They are meant to support clinical decisions. The automation component of AI in a process would be where there's low risk, high volume, high approval rates in the human process, and where the AI is able to replicate the human process and exceed the consistency of the current human process. That is the appropriate use case to automate approvals using AI, but denials should never be rendered using AI automatically. So that is my clinical opinion. That is my domain expertise opinion, and that is the position of our organization as well. Dave, you have anything more you want to add to that?
I was just going to say that generative AI can be a useful tool, right, to address, right, to essentially bring forward clinical documentation, right, surface documentation, surface guidelines, right, for a clinician to make that decision, right. Ultimately, right, it's not an AI denial decision, but it's really in the case of sort of questionable services, use AI to really surface the relevant information so that you're able to sort of quickly get to the sort of core, sort of fact-based, right, sort of implications of the denial decision. So, but it's really a support tool, right? As Liz said, you've got a human clinician who's making the denial decision, and we're really talking about using AI both to look macro level at the effectiveness of policies and then within the process to support auto approvals.
Thank you. Our next question has come in, and it reads, how can organizations determine the best approach to address for their specific needs?
I think there's several things to be considered. First is starting with the data and understanding the current state, and that's data around people, process metrics, current state outcomes, and data around the current workflow. Identifying data and technology enablers and limitations in the current operational model. So an example here is, are you on a modern platform that easily integrates with other adjunctive supportive technology? Or are you on a less modern architecture in your care management platform where it's difficult to connect and integrate with different solutions? Do you have multiple systems? Some organizations have a different system per line of business due to the evolution of their organization, acquisitions, all the natural things that happen. So looking at those complexities to seeing if they're limiting in your ability to address I think it's important to identify the desired program outcomes, and then define the metrics that would be necessary to support those outcomes. So things like turnaround times, volumes, productivity, right at the operational level. At the member and provider level, what are those experience indicators that can be monitored to show that form of outcome measurement? And then kind of hardcore utilization indicators, trends at the provider level, state level, line of business level, and how is that impacting overall medical cost? And I think most important is, what is the use case in solving the problem? What is that immediate next best action to achieve those actions? So if you put a process in place and you're transforming and you've defined the outcomes, the metrics you need to look at, what are you going to do when you see those metrics not performing as necessary? So kind of have a bit of an at the ready strategic approach for a next best action should something not be performing as intended. So those are some things to consider, in next best approach. And I think the uniqueness here is it's never a one size fit all, right? Even within your organization at the program level or the line of business level, it sometimes isn't always a one size fits all.
Thank you. The next question has come in, and it reads, can you elaborate a bit on the gold carding concept? Have you seen any health plans adopt this model and any data to back it up?
You want to start that one, Dave? You want me to?
Yeah, sure. I'm happy to get started, and you can add to it. So the gold carding concept has been around. It is not a new concept. It's been around a long time, and the idea is for providers that meet, right, that sort of are viewed as being following evidence-based guidelines, right, and sort of being sort of proponents of, right, of delivering medically necessary services, right, and essentially providers that you say, well, they don't, the notion is, hey, this set of providers, understand our sort of utilization management principles, and they practice that way, right? It's part of their core practice, and therefore, let's ease the administrative burden by eliminating those controls. And so, that's been deployed, right, in various stages over time. It's certainly, with value-based care programs, right? A number of years ago, there was a significant sort of, that was oftentimes a component. Hey, participate in value-based care, a partnership between payer and provider, because value-based care creates incentives around managing utilization, and in exchange for your participation, we'll eliminate some of the auth-related administrative requirements. And so varying degrees of success with gold carding over time. I think the biggest consideration that we think is important to keep in mind and think about is the notion that provider systems are dynamic, right? And following evidence-based care, right? The notion that you can just sort of eliminate those controls and that utilization will continue, right? That sort of the same evidence-based practice will continue ongoing. In some cases that's not necessarily the case, and so periodically, we'd suggest that it is important to be looking at data on an ongoing basis, right? Well, by eliminating these controls, will there be other other unintended consequences, and or if this is at a group level, right? If the constituents of the group, be them the clinicians themselves or folks in the right in the billing office, right? If as staff change over time with a provider, right, things, the billing practices can change as well. And so the idea would be implementing those gold carding principles can make sense in a very, targeted way, and using data on an ongoing basis to really, sort of continue to evaluate the effectiveness of those programs. Liz, anything you want to add?
No, actually, in the interest of time, we have people dropping off.
Okay.
We're at the top of the hour. So.
Okay. All right.
So I want to thank you both. We certainly appreciate you being here and for your expertise. And we want to thank you for that great presentation. And thank you to the audience for participating in today's webinar and for completing the survey that you will see on your screen shortly. And thank you all. Have a great day.